guidance. So, Rosella.
Yeah. So, good morning everyone again. It is a pleasure again for me to be here in this second day, and during this talk, in the next 20 minutes, I will discuss about the ultrasound-guided embryo transfer, and I will try to answer also to this challenging question: can we identify the optimal implantation point? And maybe is the 4D ultrasound helpful for us to answer to this question? So I have nothing to disclose. At the conclusion of this talk, of this presentation, participants should be able to appreciate, of course, the benefits of ultrasound-guided embryo transfer and to understand the benefit of the 3D ultrasound to assess the localization of the embryo flesh and identify the optimal implantation point, and review the technical aspects of the embryo transfer procedure. We all know, as reproductive doctors, that the transfer is just the culmination of a demanding IVF journey. And of course, we also know that pregnancy rates are affected by a variety of factors, such as difference in embryo transfer technique or the use of the ultrasound guidance, and of course, the skills of the individual providers that may affect the success rate. It is estimated that a poor embryo transfer technique may be responsible for the 30% of IVF failure. So, of course, we should focus on the importance of the use of the ultrasound in embryo transfer, and also just to answer to this question, how much of that 30% can we recover today using, for example, 3D or 4D ultrasound-guided embryo transfer? The embryo transfer technique gradually evolved from the clinical touch to the ultrasound guidance, and now we believe that it's the time to introduce 3D or even 4D ultrasound guidance. The use of the abdominal ultrasound to guide embryo transfer was first discussed by Strickler back in 1985. He postulated that this would allow accurate and atraumatic positioning, of course, of the catheter tip near to the uterine fundus. And then, after the Strickler's paper, we wait 30 years to have this consensus that was reached in 2016. This is a Cochrane systematic review that includes 21 randomized control trials and conclude that, of course, ultrasound guidance improves the clinical pregnancy rate compared with the clinical touch technique. They even found differences in live birth rate without increasing of chance of multiple pregnancy, ectopic pregnancy, or miscarriage. And then, of course, finally, in 2017, also the American Society of Reproductive Medicine published this committee opinion recommending transabdominal ultrasound guidance during the embryo transfer that improve, of course, pregnancy rates and live birth rates. So let's take a look on practice. This is an embryo transfer under 2D ultrasound guidance, and you can see how it is the identification of the cervical canal and the endometrial cavity. And the ultrasound can facilitate an atraumatic penetration of the catheter into the uterus and minimizing, of course, endometrial trauma. And one of the other advantages that we have with the 2D ultrasound-guided embryo transfer is that the physician is able to visualize, of course, the catheter tip, as I already mentioned, but also the final position of this air bubble, the embryo flesh. This is just on a longitudinal plane because now we are just talking about 2D ultrasound guided. The level of the difficulty of the embryo transfer has also been the subject of the investigation, of course, because we know that, of course, we know, of course, that harder is the embryo transfer, lower is the success rate. In this video, you can see how, despite a good 2D image quality, the passage of the catheter through the cervix is challenging. So, with the abdominal ultrasound guidance, speculum adjustment to the correct cervical angle, and the use of the rigid guide, finally we achieve the passage. But so we know that longer is the procedure and more it's the uterine manipulation, lower is the success rate. So how we should approach to a difficult embryo transfer? Does it matter? Of course it's matter. And here we can see that it has been published that, of course, with difficult embryo transfer we have a lower pregnancy rate. So just improve our technique, we can have the same successful rate with easy or difficult embryo transfer. How to approach a difficult embryo transfer? It has been proposed that, for example, patients with an history of difficult embryo transfer may benefit from an hysteroscopic evaluation and possible modification of their cervical canal before a future IVF attempt. So we know how to treat this patient thanks to Dr. Janusz Polski, that in 2000 published a prospective case series with difficult embryo transfer and demonstrated that an hysteroscopic evaluation of the cervix and placement of a Malekot catheter that you can see here, that it's a useful technique and allows easier entry through the cervical canal. So here you can see the Malekot catheter positioned in the uterine cavity. Typically, we leave this catheter 7 on 15 days, of course with antibiotic coverage, and then we will remove it on a baseline ultrasound. More recent literature, and maybe also with other perspectives, the future direction that of this field is focusing not only just to improve embryo transfer technique, but also to predict the difficult embryo transfer in advance. This is a publication on human reproduction, really recent. It's from April 2025. And this group proposed a predictive screening tool based on an ultrasound method to anticipate the embryo transfer difficulty. So this ART-ET tool evaluates, it's based on ultrasound parameters, and it evaluates the uterocervical angle, the uterine position, the cervical canal, and structural abnormalities of the uterus. So why we start to use 3D ultrasound or even 4D ultrasound? Let's take a look at what literature shows us until now. This is a randomized controlled trial that tried to compare 3D ultrasound-guided embryo transfer and 2D ultrasound-guided embryo transfer. As you can see in this graph, the blue bar represents 3D ultrasound-guided embryo transfer, the red bar the 2D guidance, and the author did not find significant difference in the ongoing pregnancy, implantation, clinical pregnancy rate, miscarriage, and ectopic pregnancy rate. Then the same group in 2020 published just this update, extending the follow-up to live birth rate. But again, no difference between the 2D ultrasound-guided embryo transfer and 3D ultrasound-guided embryo transfer. One of the aspects that is certainly important and yet still unclear is what is the ideal localization of the embryo placement. And maybe to answer to this question, the 3D ultrasound or even the 4D ultrasound can have a role. This is the first paper addressing the use of the 3D and 4D ultrasound-guided embryo transfer, published in 2005. They evaluated the use of the 3D in conjunction with the 4D ultrasound using the maximal implantation point in order to facilitate embryo transfer and potentially improve pregnancy rate. The authors defined the maximal implantation point as the intersection of two imaginary lines, one originating on each fallopian tube. This prompted us, our group, to conduct the following study that it was presented more than 15 years ago at the American Society meeting, to test the hypothesis that the implantation rates vary with the precise placement of the embryo within the uterine cavity, as visualized by three-dimensional ultrasound. This was a prospective study of 78 egg donation patients. All transfer were under 2D guided ultrasound guidance, and then a 3D volume of the uterus was acquired immediately post embryo transfer and stored for a subsequent evaluation by 2 blind investigators. The following measures were recorded on the coronal view, looking for the embryo flash, implantation, and pregnancy rate that were determined. This is a video, and with this video I just want to show you how we perform a 2D ultrasound guide embryo transfer. You can see here the deposit of the embryo flash, and then just after this we perform the 3D ultrasound to make the measurement in the coronal plane, and then of course also in the sagittal plane. This is the coronal plane, and you can see the embryo flash and then all the measurement. The flash on the fundus, okay. And this is the sagittal plane. So 3D ultrasound, of course, allows us to visualize the embryo flash and identify the final position of this on the coronal plane. Here you can see it again. And our results reported that the implantation rate is higher when the embryo is deposited, so it's put at 9 millimeters from the uterine fundus and equidistant from the ostia. So, of course, based on these results, we have modified our embryo transfer technique with the intention of depositing the drop as close as possible to this optimal implantation point. The next point now is about our knowledge of the embryo placement and then the development, of course, of the gestational sac. Since 2000, it has been reported that 80% of the embryos that were implanted were in the same place as where the embryos were originally deposited. So, as we can find in literature, the embryo flash, of course, it's our essential guide, but it's not something static, it's dynamic. And we know also, in particular, that the final position of the embryo flash within 16 minutes of transfer is our key prognostic factor, but also, thanks to this publication by Saravelos et al. In 2016, we know that the embryo can move following the transfer, and that when the embryo flash is moving towards the fundus, we have higher pregnancy rate compared with the cervical migration. So always based on this literature, our group decided to conduct this prospective study. This was a poster from the ESHRE meeting in 2023. We analyzed 292 single blastocyst transfer, resulting in 139 successful pregnancies, by comparing the 3D ultrasound embryo flash at transfer with the gestational sac position at 5 weeks of pregnancy. And the results show that the embryo remains stable laterally but often moves vertically. How we performed this study: a 3D volume of the uterus was acquired immediately post-transfer in the subgroup of the 139 pregnant patients, and then a 3D ultrasound was done at 5 weeks to identify the gestational sac and stored for subsequent evaluation, always by 2 blind investigators. The localization of the gestational sac was compared with the embryo flash placement immediately post-transfer, performing exactly the same measurement for the embryo flash and for the gestational sac. Here you can see how we make the measurement on the coronal plane after the transfer, and again at 5 weeks of pregnancy for the gestational sac. Our results shows us that the mean distance from the embryo flash to fundus was 9 millimeters, and the mean distance from the gestational sac to fundus was 11 millimeters. Again, no lateral displacement of the embryo was observed, and also we observed that the embryo moves toward the cervix before implantation. It could be simply a consequence, for example, of the uterine growth in early pregnancy, but it's also possible that because of the uterine peristalsis. So now what about for the ultrasound for the embryo transfer? Published evidence supports that the continued use of 2D ultrasound, of course, in routine clinical practice is, in this moment, our gold standard. And this is a recent meta-analysis, and we still don't have sufficient evidence to draw firm conclusion regarding the use of 3D and 4D ultrasound. So we need further evaluation. To evaluate the technical feasibility and visualization quality of the 4D guided embryo transfer, our group first conducted this study using just mock transfer. So mock transfer under 4D ultrasound guidance. This allowed us, of course, to analyze the performance of the electronic probe and the embryo flash visibility in a controlling setting. Here you can better see how we perform the mock embryo transfer in 4D HED live acquisition. Yeah, here you see the sagittal plane, and then in the same time the in vivo acquisition in 4D HED live. But while we have successfully performed in vivo 4D transfers in our clinical practice, it is important to know that, of course, implementing these as a daily routine required advanced high-resolution technology that is not yet widely available in the routine clinical practice. Therefore, of course, this feasibility study serves as a critical first step in defining the clinical standards for the technology before it can be adopted in large scale. And this is an example of a real 4D ultrasound-guided embryo transfer that, as I mentioned before, we perform, but of course it's hard to perform day by day in our clinical routine. So, while 3D and 4D ultrasound provides superior spatial precision and identifies the optimal implantation point through the coronal plane imaging, of course, both had advantages and limitations. The limitation of the 4D ultrasound probably it's also the advantages in the same time, because of course we have this technique in vivo, but the fact that it is in vivo, it's also the difficulty of this technique, because we need, of course, a second trained operator to perform the procedure correctly, and also because it's difficult to control the final position of the air bubble in vivo. In the same time, it allows us maybe to better predict the position of the embryo flash and the maximal implantation point. So, my take-home messages, of course, ultrasound has become an indispensable tool to monitor and verify embryo transfer procedure. The use of ultrasound guidance is an integral part of the perfect embryo transfer technique and is only expanding to improve and may include 3D and 4D ultrasound. And to answer at my first question, of course, we can identify the maximal implantation point and the better localization of the embryo flash. And last but not least, patients feel comfortable having the ability to visualize the final step of this difficult process. Thank you for your attention.